Hi, welcome to our newest edition of the ASGE Guideline Podcast. I'm Bashar Qumseya, the chair of the Standards of Practice Committee, and I'm happy to be joined today by my good friend, Dr. Madhav Desai. And today we're going to be discussing our guideline, and which I believe is one of the most important guidelines for the public and for our practicing gastroenterologists. And it is titled the ASGE Guideline on the Diagnosis and Management of Gastroesophageal Reflux Disease in this month's edition of GIE. Thank you, Madhav, for being here.
Thank you, Dr. Qumseya, and thanks for leading this guideline.
Thank you. We also want to recognize Dr. Wenli Rowan, who is also a lead author and a first co-author, along with Dr. Desai, and she could not be here today because of a personal situation. So we want to recognize her effort as well. So welcome again, Madhav. And this is an important guideline because acid reflux affects a very large percentage of the US population, and a lot of endoscopy is done annually in the United States for acid reflux. Before we delve into this guideline, let me just remind our viewers that our guidelines are based on systematic reviews and meta-analysis and literature review that is comprehensive and based on the GRADE methodology, in which we try to look at all the available evidence and summarize the best available recommendations that are patient-centered, but also physician-friendly and easy to implement. So with regards to acid reflux disease, Madhav, the first question that comes to mind, you see a patient in the clinic and they have acid reflux. When do you consider doing endoscopy in that patient?
Absolutely. Acid reflux disease is probably one of the most common gastrointestinal condition for which we see patients for, sometimes also in hospital or ER settings, but primarily in ambulatory setup. And after reviewing their clinical history, first thing to understand if they have any alarm symptoms. This includes trouble swallowing, dysphagia, painful swallowing, odynophagia, any substantial unintentional weight loss, concern for any gastrointestinal bleeding in the form of melena, black stools, persistent vomiting symptoms, or unexplained iron deficiency anemia. These are the situations or scenarios where an urgent evaluation should be considered.
Excellent, excellent. So we talked about alarm symptoms. What about patients who don't have these alarm symptoms, but have chronic acid reflux? In which situation, especially in adults and in children/infants, would we suggest doing an endoscopy?
Yes, that's an important question because infants and children, because of their method of presentation, and sometimes they are not able to manifest the symptoms similar to adults, and sometimes these are difficult things to pick up. They could be having poor weight gain, unexplained anemia, concern for GI bleeding, recurrent infections including pneumonia, regurgitation, or vomiting. And if they are having any manifestations similar to this, they could undergo upper endoscopy as well for further evaluation.
Excellent. And of course, we mentioned patients who are at risk for Barrett's esophagus. Of course, the ASGE has a guideline on screening for Barrett's esophagus, which we summarize here as well. So basically, if you have a family history of Barrett's esophagus or esophageal adenocarcinoma, you should be screened at least once. Or if you have reflux, acid reflux plus other risk factors like you are over the age of 50, male gender, white race, smoker, or obese, those are all possible risk factors for which an endoscopy is needed and should be kept in mind. So we summarize that as well in this current guideline. Excellent. Madhav, we also summarized two special populations, the first of which is near and dear to my heart because I have studied this before, is patients who have sleeve gastrectomy, surgical laparoscopic sleeve gastrectomy. What did we find, and what is the most current guideline recommendation, which is a new recommendation for the ASGE and for GI societies in general?
Absolutely. So patients who undergo sleeve gastrectomy, they have higher incidence of gastroesophageal reflux disease related manifestations, including erosive esophagitis and sometimes Barrett's esophagus as well. We extensively reviewed this literature, and we found existing systematic review and meta-analysis led by you. And we found that there is a higher risk of Barrett's esophagus in the long term. So the panel recommended, actually suggested, because of conditional recommendation and very low quality of existing evidence, that patients who have sleeve gastrectomy and reflux symptoms, endoscopic evaluation is suggested. If they are asymptomatic, then endoscopic screening should be considered every 3 years. And then if there are no findings, including Barrett's esophagus, then it should be repeated at 5 years. Now, if Barrett's esophagus is found, then they should follow existing ASG guidelines for Barrett's esophagus surveillance.
Excellent, excellent. So, we know sleeve gastrectomy is one of the most commonly performed bariatric procedures in the country, and this is very important recommendations, certainly for us as gastroenterologists, but also for our surgical colleagues and primary care providers, that starting at 3 years after sleeve gastrectomy, patients need to have an endoscopy, and if negative, then they can have it every 5 years. So that's an important population that should be kept in mind, and this is something that we are paying attention to now. What about patients who had POEM for achalasia? What did we find about this patient population, acid reflux, and when should we do an endoscopy on them?
Literature is evolving in field of POEM very rapidly, and we found 3 existing systematic review and meta-analysis, and we summed up the evidence that patients with POEM and those who have symptomatic acid reflux, endoscopic evaluation is suggested. And the provider should be aware that GERD-related manifestations are common among these patients, and many times they are asymptomatic. So they should consider endoscopy when needed.
Excellent, excellent. Okay. Well, we've said who should have endoscopy in special populations. So if somebody comes to you and you're doing endoscopy and the diagnosis or the indication is chronic, any of the above indications, you're suspicious of acid reflux, the guidelines set up some standard parameters that should be done as a strong recommendation. Can you go over these for us? What should we be looking at? What should we be measuring and taking pictures of?
Yes, this is a very important subject for patients who is undergoing endoscopy for acid reflux related symptoms or possible adverse effects. And standard reporting should be and must be performed by all the GI endoscopy providers. And that's why our goal was to review literature and come up with a standard set of criteria that should be looked into. This includes evaluation for any complications related to acid reflux disease, and also evaluation for the anti-reflux barrier, which is very important not only for the gastroenterologist treating the patient, but also for the surgeon who might be taking care of this patient. Based on our evaluation of the literature, we strongly recommend that patients who are undergoing endoscopy for GERD symptoms, careful endoscopic evaluation, reporting, and photo documentation should be performed. This can be divided into 2 categories. One for objective GERD findings, when present, should be reported using appropriate classification. Erosive esophagitis using Los Angeles classification system, Barrett's esophagus if it is present using Prague classification, and evaluation for any existing peptic stricture. Second, gastroesophageal junction, landmarks, and integrity should be evaluated. Hiatal hernia dimension should be reported either using newly published American Foregut Society grading in forward and view and retroflexion view, or Hill grading. Location of the top of the gastric folds, squamocolumnar junction or Z-line, and diaphragmatic impression should be reported separately in the report. And if patient underwent previous surgery, including fundoplication, a detailed description should be provided regarding what type of flap valve morphology is patient having.
Excellent, Madhav. This is also a very important recommendation, as well as being a new recommendation. And as I used to say, we used to just glance over the GE junction during endoscopy, but now because we can do things, endoscopic procedures specifically, which we will talk about soon, it is very important for anybody having an endoscopy for the indication of acid reflux or symptoms of acid reflux to have careful examination of the GE junction, as you discussed. So that's a very important recommendation, and it is a strong recommendation that we hope will improve patient care. All right, so now we'll come to management of acid reflux. We're going to go briefly over what lifestyle changes have been proven to help patients who have acid reflux.
Certainly, there are various lifestyle measures that can be applied first, and these are mostly conservative, cost-efficient, and non-invasive measures that should be discussed with each and every patient with acid reflux. We extensively studied the literature and found that weight loss for patients who are overweight or obese, smoking cessation, elevation of the head of the bed, and avoiding meals within 3 hours of the bedtime are strongly connected with decrease in GERD symptoms or objective parameters related to GERD, including acid exposure time. So we recommend that lifestyle modification should be offered to these patients.
Excellent. Those lifestyle modification make sense anyway, as far as weight loss, smoking cessation, and things of that nature. So that's important, and we should be recommending that to all of our reflux patients. Okay. What about the role of a PPI? This is an evolving role. There's a lot of controversy about PPI, long-term PPIs. I'm now seeing a lot of patients who are referred to me because a nephrologist wants to stop PPIs. A lot of patients are worried about osteoporosis, dementia, etc. So what did we recommend about PPI use?
We found existing network meta-analysis of almost 22 randomized controlled trials examining the role of proton pump inhibitors for management of GERD symptoms as well as erosive esophagitis. And we studied all literature also for the adverse events. We found an existing randomized controlled trial examining whether adverse events occur at a higher rate among users of PPI at 3 years. And based on the literature, in patients with symptomatic and confirmed GERD with predominant heartburn symptoms, we recommend that medical management with proton pump inhibitors at the lowest possible dose for the shortest possible duration of time should be performed while initiating the discussion about long-term management options. So yes, medication should be attempted if GERD symptoms are present and acid reflux is confirmed on endoscopy or other means. But at the same time, there should be a plan in place for optimization of the dose and de-escalation when possible.
Excellent. So this is a strong recommendation with moderate quality of evidence, and it is an important recommendation because here we're saying the lowest possible dose for the shortest period of time and initiating discussion about long-term management. What I try to teach the fellows is for many years, gastroenterologists have been used to giving PPIs forever, and we see patients on PPIs for many years, 10, 20, 30, 40 years. And what we are trying to this guideline is that this may no longer be the best course of action, and other options for reflux management is important. Okay, what about patients who have suboptimal PPI therapy? It used to be that we think, okay, maybe they're not taking the right medication, maybe they're not taking it correctly, which is still important. But what else did we recommend for patients who have suboptimal response to PPI therapy?
Yes, after confirming whether they are taking the medication appropriately as you intend them to do, we should evaluate for role of CYP to C19 polymorphism, as all the PPIs, majority of them undergo metabolism through this pattern, and individuals could have different genetic polymorphism, and based on that, they could be ultra rapid metabolizers or slow metabolizers, and that should be considered and evaluated. When we examined the literature, we found that this is an important situation nowadays, as many of the Caucasians are actually ultra rapid metabolizers. We suggest that in patients with suboptimal clinical response to proton pump inhibitor therapy, testing for CYP2C19 polymorphism and adjusting the PPI dosage or selection of appropriate medication should be performed when they are not responding adequately.
Excellent. So, frequently when we check for CYP2C19 and they are rapid metabolizers, And then the options would be to switch to aripiprazole, which is not metabolized as much by CYP2C19, or increasing their PPI dose to TID. If they're on pantoprazole, which is one of the weaker PPIs, maybe switching them to something else like omeprazole. Excellent recommendations. What about the role? I know this is a developing topic of new classes of medications for PPIs, for
Yeah.
acid reflux.
So at the time of our systematic review of the literature, we found that vonoprazan was almost available in many countries, but may not be readily available in North America due to various issues. It might be available for H. pylori. We found one existing randomized controlled trial. We suggest that this medication should be considered in the armamentarium. However, at the current moment, it is difficult to come up with a positioning statement, but hopefully in the near future, we will have more long-term safety data, which would help us, select their positioning in the management of gastroesophageal reflux disease.
Yeah, so vonoprazan has recently been approved for chronic GERD as well. It does continue to be difficult to get based on insurance coverage, which doesn't seem to cover it most of the time, but it is something that is available to somebody who's not responding to PPIs. And the difference, also one of the important differences, is you don't have to take it half an hour before a meal, unlike PPIs. You could take it at any time, unlike PPI. So that may be beneficial to some patients. All right, so excellent. What about patients who have persistent GERD, and when do you consider endoscopic evaluation to perform transoral incisionless fundoplication as compared to medical therapy?
We reviewed the literature for endoscopic therapies. There are different forms of endoscopic therapies available. Some are targeted at creating endoscopic fundoplication when the hiatal hernia is small in size, including less than 2 centimeter, or Hill grade of 1 or 2. This is probably a smaller subset of GERD patients, but an important subset of patients. When they have regurgitation, they may not respond adequately to medications because of the volume reflux. We found 5 existing randomized controlled trials, and we performed systematic literature search and meta-analysis of eligible studies. And we found that in patients with confirmed GERD and small hiatal hernia, or Hill grade 1 or 2, who meet criteria of chronic acid reflux symptoms at least for 6 months, chronic proton pump inhibitor therapy for at least 6 months for management of these symptoms, refractory symptoms, or regurgitation predominant symptoms, and patients who prefer to avoid long-term medications, including PPI, they would be they would benefit from evaluation for endoscopic therapy, including transoral incisionless fundoplication or TIF2 in the current iteration. So ASG suggests that this patient should be evaluated for TIF as an alternative to chronic medical therapy management.
Excellent. So again, to go over the criteria, this is a new recommendation, an important recommendation that was not previously available by any GI society in the US. So if patient has chronic GERD defined as GERD for more than 6 months, chronic PPI use more than 6 months for the management of acid reflux or regurgitation, heartburn or regurgitation, refractory GERD that is not responding to medical management and lifestyle changes as previously summarized, regurgitation predominant GERD, and patients who prefer to avoid long-term PPI use. All of these patients can and should be considered for endoscopic therapy. So what about patients, as you mentioned, who have a hernia more than 2 centimeters or Hill grade 3 or 4? What did we find in our literature search, and what can be offered for these patients?
Yes, and this could be a substantial number of patients who have a decent size hiatal hernia more than 2 centimeters. We found 7 existing cohort studies, and we perform meta-analysis for this. And based on literature review and existing evidence from the GREAT panel, the ASG suggestion is that in patients with confirmed gastroesophageal reflux disease and a large hiatal hernia and Hill grade 3 or higher, we suggest evaluation for combined endoscopic transoral incisionless fundoplication with hiatal hernia reduction surgery or conventional surgery. And this should be performed in multidisciplinary team review fashion. So this patient should see a surgeon who has expertise in performing surgery accordance with a gastroenterologist who is well capable of doing TIF procedure. So it should be a combined approach, or this patient should pursue conventional surgical therapies, and that should be discussed in a multidisciplinary fashion.
Excellent. And I also noticed that at the time of recording this interview, there is a randomized control trial that supposedly finished recruiting but is not available yet, specifically comparing CTIF, which is concomitant TIF procedure, and hiatal hernia repair compared to Nissen fundoplication. So we await the result of this randomized control trial to see how these two interventions compare. Excellent, Madhav. So we also identified a lot of other methods for endoscopic management that we made a summary of in the table. I'm not sure if you want to highlight any of them in specific. Many of them are still not ready, and some of them may have too much adverse events and are not suggested. Do you want to comment on any of them?
Yes, there are various endoscopic therapy options available, and this include radiofrequency energy to the lower esophageal sphincter or strata. And this was examined in 4 to 5 randomized controlled trials almost 15 years ago. There hasn't been significant updates on the literature. There has been issues with delivering the energy, availability of the instrument, and then available personnel who can do the um, endoscopic therapy. However, we suggest that, and we considered that this could be an alternative modality that could be discussed with the patient when standard endoscopic therapy or surgical therapy options, including fundoplication, are not available locally, or if they are not feasible, and when patient is otherwise a candidate, including confirmed acid reflux and small hiatal hernia less than 2 centimeters. There are other endoscopic therapies, including mucosal ablation, or called as ARMA, or mucosectomy, ARMS, and this could be considered as an alternative as well. However, currently the existing literature is not sufficient for us to come up with a positioning statement or any recommendation.
Excellent, Madhav. That's an excellent summary. And I am very excited for this guideline. I hope that our users and our gastroenterologist colleagues, endoscopists, surgeons will review this guideline favorably and will use the evidence here as I am teaching my fellows now in the clinic and in endoscopy. The days in which we just gave medications for PPIs may be over. There are a lot of things that we can offer these patients. Our patients deserve the best available treatments, and this is an evolving disease. Excellent. Thank you, Madhav, for an excellent presentation, and thank you for your hard work, you and Wenli as well. As I have been teaching the fellows, the management of acid reflux has now changed, and we are moving on from just giving people medications for the rest of their lives. The patients deserve the best treatment available, and this guideline offers the best available literature review and evidence-based recommendations for physicians and clinicians to be able to use. We have also made this guideline very unique in the sense that we put in different classifications that you can use. For example, the LA grading for esophagitis, the Prague classification for acid reflux, and the AFS hiatus grading as well. And those are available in the guideline, as well as a diagram that can be downloaded and printed and can be used in your day-to-day in the clinic or endoscopy as far as patients with acid reflux, one to do endoscopy, one not to do endoscopy, one to do testing for CYP2C19, what endoscopic findings to look for, and when to consider endoscopic management. Once again, thank you so much for working very hard on this guideline, which is a very important and influential guideline, and we hope that everybody will find it helpful and have a great day.
Thank you, Bashar, and thanks, Lauren, also for your continuous support and guidance on this important subject. And thanks, Dr. Ruan, who couldn't join us, but this was an important topic, and I'm hoping that this will be beneficial to all the gastroenterologists and community, since this is one of the common things we see. Thank you.
Excellent. Have a great day.
Have a good day. Bye-bye.